Zelo dragocena dobrina, vas bom prosila, da počasi poiščete svoj stolček, da z današnjim dogodkom in letošnjo konferenco tudi uradno začnemo. Tako, spoštovane in spoštovani,
So, ladies and gentlemen, it is nice to see so many of you here. I see many old friends and acquaintances, and I have to say you look better from one year to the next. And I believe this is also somewhat related to this year's topic of our strategic conference entitled The Value of Innovation. With the assistance of scientific discoveries and knowledge, we managed to extend our lives and the quality of our lives into the so-called third youth. And thanks to the increasing number of innovations, including in healthcare, we'll be able to live well and to the full. However, given the limited spatial and human resources, this will only be made possible if we make sure that innovation in healthcare remains at the forefront of importance, at the top of the agenda, which means that we will need to manage our resources wisely, prudently, and strategically.
It is my great pleasure to welcome you to the 13th Strategic Conference on the Value of Innovations. Today we gather to explore and celebrate the transformative power of innovation in healthcare. This conference serves as a platform to share knowledge, inspire creativity, and build partnership that will shape the future of healthcare. Letošnjo konferenco smo podnaslovili prepoznavanje potencialov v zdravstvenem
is entitled Identifying Potentials in the Health System to Foster Innovation. The International Forum of Scientific and Research Pharmaceutical Companies is organizing this year's conference in cooperation with the Association of Healthcare Economists. Together with our speakers, we will focus on the strategies for effective research management in the healthcare system with a view of reallocating resources in favor of breakthrough innovations. I'd like to therefore ask the chairman of the board of the International Forum of Scientific and Research Pharmaceutical Companies, Mr. Yuri Stariha, to give us the introductory and opening address. The floor is yours. Distinguished guests, dear lecturers, ladies and gentlemen, including everyone who is present virtually, welcome to the strategic conference on the value of innovation, the topic of which will focus on identifying potentials in the health system to promote innovation. Once a year, this conference brings together all the different experts in the field of healthcare, and it gives me a great pleasure that so many of you came here today. We are co-organizing this conference together with the Association of Healthcare Economists. Approximately 75% of all global deaths are caused by diabetes, cardiovascular diseases, cancer, and respiratory diseases. The treatment of all of these conditions is very burdensome on public expenditure. For instance, more than 50% of all costs related to diabetes is related to the complications, which means that individual diseases are discovered, diagnosed too late, and the treatment is also taking place too late in the stage of disease development. This, of course, brings ever greater costs for the healthcare systems. It is our belief that we could do more by employing innovation and innovative approaches. And that's why we decided to showcase certain cases which will hopefully pave the way for the future of our healthcare system. These lecturers and presenters will show us how critical the integration of innovation in our everyday work is, how critical it is to take on board the recent discoveries of research studies, and how important it is to take on challenges in this respect. Innovations not only in medicine and pharmaceutical industry, but also in healthcare processes can indeed bring about a better, more quality healthcare and more concern for patients. This will, of course, also contribute to better health outcomes. I look forward very much to discussions, to new partnerships that we will hopefully come up with today, because this conference is not only an important opportunity for finding out new information, but also for mingling. Thank you for joining us on this path. Thank you, Mr. Stariha. I would also like to welcome everyone who are following us remotely and virtually, and of course I would also like to warmly welcome all of you who took your time off and joined us here at Cankero Dom. We are living in an aging and a long-lived society, which means that there is an increasing demand for healthcare services. At the same time, we're faced with labor shortages, limited financial resources, and ever new treatment options. That's why it's important to know the needs and capabilities on the other hand. It is important to make well-informed decisions. It is important to plan carefully for future needs, both in the short and long terms, as well as to develop strategies that will help us in allocating the resources which are already available in a way that maximizes their impact. A great deal of work in this respect should also be done by the Ministry of Health. Unfortunately, the Minister, Dr. Valentina Prevolnik-Rupel, was not able to be here today due to other urgent commitments, but she did prepare a virtual address.
Unfortunately, we cannot hear the speaker. How once again we are going to come back
Spoštovani,
to this video
veselje mi je,
address.
da vas lahko nagovorim ob začetku že 13. konference o vrednosti inovacij. Ta je letos posvečena strategijam za učinkovito upravljanje virov v zdravstvu z namenom prepoznavanja potencijala za spodbujanje inovacij. Spodbujanje inovacij je prednostna naloga mnogih držav. Enako pomembna pa je tudi dostopnost, kakovost in vzdržnost naših zdravstvenih sistemov. Med temi cilji lahko kaj hitro pride do neusklajenosti, ki jih moramo blažiti z razvojem ustreznih politik inovanja in ukrepov ter rešitev
by introducing measures and solutions for a healthier society. It is expected that by 2030 the share of people older than 65 years will increase from 21% to 24.7%, meaning that 1 in 4 persons will be 65 years or older. The needs for healthcare services will keep on growing, and the expenditures too. Also, there will be an increasing need for better performance and additional investment in healthcare. A healthier society must be our common objective, because this is the basis for economic growth and prosperity. The population is aging. The incidence of chronic diseases and comorbidities is on the rise. Now, coupled with the gap in quality and safety, it becomes clear that providing for financial sustainability will remain a substantial challenge. The launching of value-based healthcare, VBHC, is a possible approach in healthcare, and this is high on the agenda of my term of office at the Ministry. This must rely on appropriate measurements of patient outcomes. Data should underlie our monitoring of patient outcomes, coupled with data analysis. This should be the basis for further decisions on health care treatment. VBHC can improve the performance of healthcare, its quality, and it can also bring about savings and better overall performance of the entire healthcare service. In healthcare, we have been witnessing enormous progress, seeing new drugs, new medical devices being developed on a daily basis, including digital tools. This is reason enough for optimism. The link between health and innovation is obvious. However, new healthcare technologies and other innovative solutions must be closely monitored and constantly measured in terms of the value that they bring. Only in this way can we be sure that they truly address the needs of patients, add value to their health, and drive further progress. The implementation of medical, technological, and other innovation brings the increased need for new skills and knowledge. Support to digital literacy of all stakeholders in the system is inevitable and urgently needed. But that alone is not enough. We need experts with advanced analytical skills, data management knowledge, and artificial intelligence skills. The potential of innovation here is enormous too. Artificial intelligence can take away the burden from healthcare professionals, enabling doctors to truly focus on providing the best possible care to patients. Digital collaborative tools can help combine and exchange knowledge between experts across the world, fostering the exchange of the best practice. Ladies and gentlemen, I wish you a successful event, an interesting debate, and constructive conclusions. Thank you very much to the team who has saved this video. This is a proof that personal presence cannot be overvalued. Now, last year, we listened to a lecturer who is with us here today in person. The first to speak today is Mr. Bogi Eliasson. We met him online last year, and he has kept the promise and is here with us today. Bogi Eliasson is the Director of Health at the Copenhagen Institute for Future Studies. He was employed over the last 25 years with politicians, the public sector, and private companies, building and steering initiatives such as FARGEN, Nordic Health 2030, and Movement Health 2030. He is the initiator of the first population genome. He builds the bridge between the public and private sector, decreasing the burden of health that are avoidable by building secondary prevention and data structures. He calls himself the mediator of health, combining knowledge in different areas of expertise. Mr. Bogi Eliasson.
You promised to visit Slovenia, and we are delighted you kept your promise. The stage is yours, please.
Can you hear me?
Now, after this presentation, Mr. Eliasson will be joined by Dr. Dorian Marušić for a questions and answers session.
No, but I can see I start 4 minutes early, so I have 4 minutes extra. Thank you so much, and thank you for inviting me and wanting to hear me, or at least that's my impression, once more. So I arrived here first time in Slovenia on Saturday. It's been very nice. I also learned yesterday that the name Ljubljana has something to do with the city of water, I guess. So I had to learn that today. I am myself from a very, very small society, the Faroe Islands. So you think you're small? Not really. This is really small, but we beat you in football sometimes, right? I had to say it. Sorry. So first, I would really appreciate that you are doing this event on a yearly basis. And I would also appreciate what you are trying to do and push as a country, because there are many things which are quite interesting, and I hope we hear some of these things in the afternoon. So what I'm trying to do in the next half hour is to take you through a mindset shift that is necessary in order to do the things that we are dreaming about. The what, I think most of us are quite clear on. The how is the challenge. So, as said, I'm from the Copenhagen Institute for Future Studies. It was established in '69 by the first OECD General Secretary and former Danish finance minister. He wanted a think tank that was independent, so not public, not private, and could bridge in between. And I normally call myself a knowledge broker, so it's about bridging the different disciplines in order to go forward. My main initiative is the Nordic Health 2030, which was initiated in 2018-19, based on that we could see when we looked into the Nordic health data and the cost of the data and also the staff in health, that this was going to break down. We envisaged that 10 years was the maximum this would survive, and then COVID came. Of course, it accelerated very much. But the idea here was also to look at the role of health as a part of the social contract. So what does it mean when you digitize societies, where you move from the jurisdictions and you actually begin to work much more outside of your own part as well? Then we also work quite a lot with indices. Right? Last year we did one on severe asthma, and now we're doing one on COPD, so one of the big diseases. The Movement Health is a more global one, where we've been very active in Latin America, for instance. And the Phase 5 is a new way to do clinical trials that we are working with many of the Danish stakeholders on how to do decentralized and digitized clinical trials on the premise of the patient, not of the others, in order to work. And that's also a part of the secondary care in that part. So one of the part that I've focused quite a lot on the later years is, so first was with ethics. I'm in global ethic advisory boards and global ethics networks. But ethics becomes very political very fast, left, right. What do you believe? Dignity we understand better. So when we do something new, how can we really assure that dignity for the person and for the group is also kept in that part? So, and of course, we are in many projects in many parts of the world. I will not go into this, but just saying that we are not just working with one approach on health. Big questions always arise. Some are fundamentals. So, are we doing the right things? And are we doing the things right? Right? It sounds very simple. But if you think through the projects that you are doing, the tasks that you have today, and really check after, are you really doing both of those things in all of the things that you are doing? It's very healthy to try to think that. And if we then do think about sustainability, sustainable health, resilience in the way that we are doing health today, we are not doing the right things and we are not doing the things right. So we need really to push. So I really like this quote from Mark Twain: reality can be beaten with enough imagination. So this is not about more of the same. It's not about lean management on what we're doing. It's not about digitizing analog processes or putting artificial intelligence on what we're doing. It's about reimagining what we want. What is it that's different today from 100 years ago? What is it we want 10 years from now, given the society is how it is? And it's not just improvement, it's rethinking. Why? So now I want you to think, when you see the next picture, it's absurd, but I want you to think what you are doing today that your kids and grandkids in 20 years will say to you, did you really think like that? So this is a commercial from the 50s from the US. It states that to be a good doctor, you need to smoke Camel. Right? But what are you doing that your kids and your grandkids in 20 years will come to you and say, did you really think like that? That's your task. You don't have to answer me today, but you can send me an email tomorrow. So we also heard in the beginning that there is a burning platform, there is an increasing disease burden, there is main focus on end-of-life solutions. Most countries spend 80% of the health budget on the last part of people's life. There's focus on disease, and there's a staff shortage and burnout. So this is very general in our part of the world. So we also have these forces coming in with demographic squeeze that we heard about, with systemic pressure that's coming in from different reasons, and then also the technology that comes in, and we just adapt it without really thinking how we want to use it. So there are pushes. What is really happening, I'm sorry about this slide doesn't look as it should, but anyway, we have seen the last 10 years of discussion on the fourth industrial revolution with biology, data, and digital, imaging also, and materials, smart materials, nanomaterials in different ways. Those pushes forward were very much about quantity. How do we get this technology to work and how do we apply it? But what we really need is getting back to the quality. So how does this get human-centric? How do we get the personalization and customization? How do we get the sustainability and ethical and social responsibility in and the human-machine interaction? So we are moving from being reductionistic, very academic, thinking like machines, to actually making this with dignity and humanity. So that is the change we will see if we want to apply these kinds of things. And this is also why interdisciplinarity is so very, very important. So we, for instance, see in the new biology or genomics that polygenic risk scores or different kinds of predictive genomics are coming on the markets quite fast over the next years, pharmacogenomics. So that's a part of the fourth and fifth industrial revolution. You also know it with data in Slovenia. You are quite advanced in some of the areas. But in Sweden, for instance, you have almost as good care in the outskirts of north as you would have in Stockholm with different virtual systems already set up. The COPD home care in Denmark is applied for all the municipalities, the infrastructure, so everybody actually can access it in that part if the municipality wants. Imaging is having a total new revolution in mixing it with different other disciplines, so you actually can use it in different ways. Of course, the data power and the new imaging technologies has a lot to do that is possible. And then smart materials in different ways is also coming in, so we will not just monitor on people, but also in people. And this is happening very fast in many, many ways. So, but still, we've never had more money in the health system. We never had more people in the health system. We never had more technology, tools, equipment, data, and knowledge. We never had more dissatisfied patients or staff. So these are 5 red points. When we have 5 red points like this, maybe something is not right. So are we doing the right things? And are we doing the things right? Probably not. So we also are in this situation because we accept that with longevity, with more age, you need to have more disease. We take it like a law of nature, that if we get older, we should be weaker and have more disease. It's a very strange way of thinking, especially if we seek sustainability and well-being. So how can we work with not accepting that the disease burden actually has to grow? So this is about reducing the avoidable disease burden, which we estimate to be 30%. So this is not about more staff. It's actually not about more money. It's about rethinking, where do we apply the technology? How do we get timing right so we go early and precise, so the first diagnostic is as right as possible and the first treatment is the right one? And it was also said before, 75% of the disease burden globally now are NCDs. Here, I think it's just over 80%. In Denmark, where I live, it's 85%. But we are still constructing our system as if it was accidents and communicable diseases that we need to deal with. We have to move from being totally acute and important to the non-acute and important. NCDs is not acute until it becomes acute because you didn't do anything. So these are the changes that we really need to get in. So questions that we really ask here is, what if health was the most important societal pillar? Not saying that it was, or that it is, but what if it was? Would you prioritize differently? Would you see society differently in that part? So social equality, equity and fairness, sustainability and growth and prosperity, to realize the well-being economy, reducing avoidable disease burden, and also to work with safety, security, and resilience. And we heard the health minister say that health is the profound foundation for well-being in the society and also growth. So this is a very old graph that we did in Denmark 10 years ago, just showing what normally happens. We know that we should begin to work here. The Chinese already said so 3,000 years ago. Nobody pays until we're here, right? Nobody invests in companies that want to be here, but you invest in companies that want to be here. So it's not just the public system, it's also the private system that's incentivized to be in that part. So we also need to think about how do we get the focus down to that part. So if we look at Slovenia, you are quite good on many areas, so I won't teach you on Slovenia because I think you'll know more than I do, but I can look a bit from outside. But of course, you are, in the big numbers, doing well on the longevity, much better than Denmark. Of course, there are numbers which you know that the numbers of doctors is low, the number of nurses is high, and then you can say, is that bad, is that good, or is that just a reality that we can use as a strength in it? Tobacco use is fairly high. You are very good at keeping women alive for a long time, but the poor men. So my daughter asked me if we should move to Slovenia, and I was saying, it's good for you. I don't know if it's good for me on those parts. So we also worked with this severe asthma index last year, and actually Slovenia is doing quite well on reducing or not having asthma deaths, and also on on the DALYs on asthma, but the hospitalization of severe asthma patients is quite high compared with other with OECD countries. And the same is more or less the case in COPD, but I was a bit puzzled by the numbers on COPD, because when you have this rate of smoking, it's a bit strange that the numbers are not higher, but that can be checked. Anyway, so, but if we look at Slovenia in the area of Central Eastern Europe, you know that you are quite well, you're quite good, so there are lots of opportunities to really push and work and show cases for the neighboring countries. When it comes to most of the characteristics, you are a little bit stronger, but in the middle on the European part. So we can still work with improving also from a systematic level. So when it comes to things that go ahead for the future, you are also very EU-friendly. There is actually quite a lot of focus on the European policy, which we don't see in all countries, which is, I think, is nice. But it's also complex to think Europe, right? GDPR and health data space and EMA and medical device regulations and genomics in different ways and the pharmaceutical regulations. So the challenge I see in a Slovenian context is the same, or one of the reasons we also pushed the Nordic Health. It's very hard to be a small country and deal with all of these things. So how do you begin to think to pull together with neighboring countries to do these things together? And it might sound a bit crazy from your side, but just think about when you have to not deal with all of these things, but also combinations of these things. So pharma with apps, pharma with medtech, and all of these things. So I do think that one of the big challenges for small countries is really how to deal with the complications or the complexity and the combinations of these different things that we need to have in place. And if we don't have them in place, we can't give the newest treatments and opportunities to our citizens. So this is my main question. What do you want? Best health system or healthiest population? And I will ask you who work with health, how many of your decisions the last 6 months were actually about the healthiest population and not about the health system? Do you take any decisions deliberately that goes for the healthiest population? Nobody answers, so no. Okay. And this is where we really begin to move from the what to the how. So it's about really going back to say, okay, what is the playing field we need? What is the playing field we want to accept, and how is it we want to work? And we need to work with a lot of data, and the factfulness here from Hans Rosling is his way of presenting, really working on what is it that works, but also that the benchmark that we work with that moves with time, and we need to be realistic in that one. 1984, you know, is my favorite book. I reread it every second year in order to understand where we are on surveillance. It's not because I want to be Mr. Winston, but it is very important also to admit that we live in a different world and privacy will be different than we know it. So what is it, the tools of today and the frames of tomorrow? What is it? And the important thing, and this is why I'm so happy with the program for the afternoon, apply what we have. Innovation without application is nothing. It's just a waste of money. So how can we apply much more of what we have? So here it comes back to what if health was the center of all climate sustainability and security efforts? So we know that health is one of the most polluting sectors, the 5th most polluting sectors. So how can we go in and work with the footprint, the carbon footprint and the waste, but also to optimize resources, but also see health as a climate investment, really go in and push it as a climate investment for the society. And these are some of the bases on this 5-5 idea that we developed with the Nordic Health. It's not my idea, it was the group of people from the 5 countries. It's based on that the Nordic countries use more or less 10% of GDP on health, whereof I think 0.3 is on prevention or something like that, very, very low. And then we went on saying, okay, what if we can get towards half of that to be preventative, so primary, secondary, and tertiary prevention by 2030, and really push in that way. And it's more a goal than anything else. And then the first part of starting that, what we are doing is saying, okay, what if we do secondary prevention with chronic disease, where we really apply the technology that we have with some diseases that are doable to work with, like diabetes, like COPD, like cardiovascular diseases, where it's really about getting the diagnostic as early as possible, as precise as possible, and then really slow down the progression of the disease, and most importantly, stop or delay the onset of second and third and fourth chronic disease, because that's where the quality of life really drops, and that's where it gets really, really expensive in the system. And here we think we can actually show proof of concept in 1 to 2 years by comparing different clinics on it. And of course, we use a lot of data in order to work with that, where we also use the indices to go back. And why we use indices is actually because we want to go beyond this one size fits all. We also really want to go beyond politics, party politics. So how do we really push with data so you can't say, no, this is left or this is right, so I can't be there. And also really go away from the sick care part. So in essence, this is about moving decisions from perceptions to facts, really to push the data, and use this to build the coalitions for change, because nobody does this alone. And then also using much more energy to make data and insights accessible so it's understandable. And with that, also build leaderships for it. And one other project that we are doing in this part is the phase 5 that I mentioned in the beginning, which is this new way of thinking decentralized clinical trials. And here it's also about what can you do. So you start on the other way, saying, what if everything you do, you actually do at home with the person? Normally, we bring patients to the clinic. They spend a whole day to sit 5 minutes with a doctor, and they go back again. There's nothing in it for the patient. And the dropout in the trials is also a huge burden for the companies who do clinical trials. So what if we do all of these automated data captures that we actually can do today? And of course, you will say nobody would want to have their data or their house monitored in that way. That will not happen. I will just ask you to think about 15 years ago when you got the first iPhone. If somebody asked you or told you that you in 15 years would pay €1,000 for a device where 50 companies steal all your data and you will happily buy it, you would say, go to hell. You still do it, right? This is going to happen with your house, because the benefits for the ones who need care are so big. And this comes back to the data governance. The privacy we are trying to apply today is analog privacy. It doesn't work. The value of data is repurpose or is multi-purpose and reuse of data. If we only want to use each data point once, we should stick to paper. We should not invest in digital technology. It's far too expensive. So the only way I can see forward on this is to apply a very, very thorough transparency, traceability, and governance on it, so you always can follow who looks into your data, and you can do that with federated data system and blockchains or ledgers. But we also need to develop the trust, the data solidarity, and the intent of the data in these models, where we have dignity and common good and social contract, but most importantly, we really need to figure out how we do this no harm clauses with the data. That's the tipping point for everybody in this. So when we look at projects, and I'm very sorry for this complexity of this slide, but what we do now is that we have a backdrop of 23 items that we look at systematically when we go in and work with ideas or projects, which are these ones. And then we check, okay, if we move these things forward, how does this relate to health and all policies, to SDGs, to social determinants, to One Health, and then estimate if this is something that's worth doing on these things. But in essence, this is about improved use of AI data, tech, materials, and biology. is about improved prevention, improved treatment, improved dignity and equity, and improved sustainability. So that is really how we're trying to drive the change in the mindset in this part. And it is in the future way of working. Sorry, can I not go back? Yeah, I can. So we always have a push from the present. So the reality we see today, we don't have staff, right? And then we have the weight of history. We need to be acute. People are dying. How do we all run to it? And then there is the pull from the future. So what does that look like with technology in different ways? So this is how we are trying to address things. And what we need to get together when we work with things is that technological, societal, and behavioral parts, there are readiness that you need to prepare. You need to work with people so they actually can take these things and realize them. And often we underestimate that you need to get these things in line to go forward. And this is where we work very much with what we call super specialization and system thinking. So super specialization is the experts, the super experts that we have. This is what we learn in university, be very reductionistic and granular. But system thinking is to connect these things. We are very good at the first one. We are not very good at the second one, but there are very few people who can do both. But the reality we want requires both things, and that is a challenge. So technical change is what we do when we improve something or make slight changes so it becomes better. We know the process. It's Gantt charts, Excel sheets. You know which time you drink coffee and when you innovate. Very controlled. That's how you get money. The adaptive change is when we know we need to improve. We need to do things differently. We can't even define exactly what we need to do. We have no idea how to do it, but we need to start. Nobody wants to pay for that. If they want to pay for it, they force you to have a workbox or a toolbox that is for technical change, and this is why we fail. You can't do technical mindset for adaptive changes. And this is also the courage and the room that we need to have in these kinds of situations. And then just a little bit back to the Nordic Health and the 5-5. We also have two additional principles here. One is the 80-20. We know that in most societies, 20% of the people need a bit of care at any given point, and 80%, with a little bit of effort, you can probably keep them healthier for much longer. So one of the priorities is how do you keep the big mass with very simple means healthier, longer, so you actually can help the 20% much better, because we are not helping them as well as we should today with the technology and money we have. And the 10-90 principle is that most of the things that we invent in health, or that is invented in health, is for the richest 10% of the world. That's the market. It's not for the 90%. You want SDGs, you want equity, you want equality, get the companies to change the 10-90. So, sorry about this aesthetic, but it was made in 2019, before ChatGPT, and you could do online images. But the idea here was, with the Nordic Health, was to say, what happens? What is it if you put the person in the center? How can you, with an AI device, not produce new data, but give them the data that they need so they actually can take more responsibility for their own health? So that was what we call the humanome model. So this is not about producing new data. It's just about an aggregator, an integrator of data. And then if we really want to work with not static data, but real-time data, 24/7, data that really can make understanding so we give better life, we need to change our mindset, because everything we have done in health and health data and personalized health has actually been about the system. It has never been about the person. It's about a better system for the person. It's not the person, right? So if you want real-time data, dynamic data, who's going to produce it? It's the person. So if we want to walk the talk of the promise of technology, we actually need to be able to bridge the individual level with the aggregated level. And also have in mind, if we don't have an aggregated level of knowledge, we can't refine the individual level. So these are very interconnected in that way. Is this easy? No. Would it end up in a lot of ethical discussions and privacy and ownership of data? Yes. But do you want to apply technology in a much better way? Probably the answer is yes. You can't get around this challenge. So we have worked a bit with this in the Nordic as well on the scenario processes. And here the question was really, what is it we are pushing? Is it a maintaining health or providing treatment where the aspirational push is much more on maintaining health? And then the question was, should it be more policy-driven or more tech-driven, industry-driven? And there the push was very much, we need to figure a way out to do that in combination. So private-public partnerships don't really exist. So how do we build that? So when the private companies do services for the public sectors, it's tenders, it's service, it's not partnerships. So how do we get and really push for a dynamic partnership where responsibilities is from both sides? So, and here we also ended up with 23 work streams. I won't go into them, but I go into data, digitalization, policy, health and economics, and sustainable use of local health innovation. But we have 33 ideas with responsible persons that we are pushing forward now really to move from the what to the how and see where we go with this and if we really can solve some of these issues. And now just a stupid comparison. I had 4 minutes extra, so I will speak a little bit more. In US, you reduced the fatal accidents with 95% per driven car or in 110 years. Because you improved the roads, you improved the cars, you improved the safety, you improved the requirements for driving, not because you built hospitals along the road to deal with the fatalities. I'm just asking, what do you think we are doing in health? Are we doing this? So this is the change we really need to get in. And this is not just about political responsibility. So that was my half hour. Now I have 4 minutes left, right? If it silence. So this is not just about the political responsibility where we always put it. This is really about rethinking the public sector administration, the corporate, your personal, but also the civil society. This is not something we can just park with the health ministry and say, this is your problem, solve it. It's too cheap. And I will tell you a secret. Politicians are very good, but they're not that good. Sorry. So the real question is not if we can afford the future cost of health, but if we can afford not to invest in keeping people healthy. That is the core question in this part. So, and that goes back to, the cost. Oh, that didn't work very well. Can I get the full screen again? That goes back to what is really the cost of inaction. What are we paying in the future for things we are not doing? And those are the calculations we are not doing. Not any health system is doing it in the world. That is what is really needed. Small country like Slovenia with that many economists, you can do it. So that can be your. So there are a lot of, I also learned yesterday that the map of Slovenia is a chicken. You don't get offended, no? So it's a small country with those advantages and challenges, of course. Health as a value driver, I think the minister was quite clear on that part today. But also seeing health as a safety and security might be a good part to go in. I have talked with some people here. I really think that the way we have worked with Nordic Health might also be a good idea to push in a Slovenian setting. So just throwing that out. And if I just go fastly through the conclusions here, so health as the most important societal pillar and health as an investment, and really to reduce the cost of inaction. So that is the pushing point to change. So the 5-5 idea, it responds to the shift to the non-acute intervention, responding to the 85% of the NCD burden, so going to the non-communicable diseases. Secondary preventions, we can already start the tools, and actually Slovenia is quite capable and is already doing on several areas here. So you're probably ahead of the curve compared to many countries on this part. Doesn't mean that you shouldn't do more. But dignity as the concept with the 5 areas, really to build systematically on how to get sustainability and fair health. And privacy needs to focus on people, not just protecting data. So privacy is about helping people. It's not about protecting data firstly. That's what we do today. So that needs a new thinking. And the humanome and the sustainability model are concepts that bridge the personal and public health to one approach. And then the super specialization and system thinking, so realizing the fifth industrial revolution in health is what I think is really, really important to focus on from the technical perspective. And then, I'm very sorry to say, but I could have done this in 10 seconds. It's all about questions before answers. That is the fundamental and most important thing. If you're only looking for answers, you stay in the box you're already in. You have to ask the questions. Thank you so much.
I think that we can move to names, since we had a lovely dinner and chat yesterday.
Yes.
Yeah, so first of all, thank you for flying and not to beat us so hard years ago in football. Anyway, so thank you for your thinking about future. But first question, is, which is prepared by my colleagues, is probably the question from the audience, you know? Tell me, did any country did what you are proposing? And how they did, and what were the steps, and what would you recommend? An example, because we Slovenian, we always want to have, give us a proof.
Yes.
That it works.
Yes, so I have to answer in a bit pushy, provocative way.
We have 10 minutes.
Okay.
Yeah.
Oh, 10 minutes.
I have another question.
So I can think as well. So there is a difficult thing with decisions and evidence and the future. There is no evidence on the future, right? And this is one of the biggest challenges we have with change, because we are so proud of evidence-based health, which I think is fabulous, that we prove that what we do works. But it's also hindering change that we know is needed often. So to answer that question, so what we are pushing here with the 5-5 has not been realized by any country, but it is a progress that we are doing to have a mindset that's changing. So for instance, in the new frame that is proposed now for the Danish health budget, it actually states that the point of care needs to be at the first possible level with the lowest possible complexity, with the least needs for education in that part. So you can go out and do health also in the social care and in those parts. So that's one example on how that's pushed forward. But this is being used also in the Nordic countries in the political setting and of the Nordic Council.
Okay, the second one. Now let's start from reality.
Yes.
Slovenia, 3% for prevention, 97% for all the rest.
Yeah.
So what would be the first step to at least double the preventive percentage? And since I'm also a mathematician, relative numbers, that means that if we increase to 6, that is going to be 94 for the audience, yeah? Because majority of healthcare workers think that 100 is not 100%.
No. Okay. Let me take this from a different approach. I was interviewed by a Dutch magazine last month, because I go there next week, on a big prevention conference. And apparently I said, I probably said, because I think this way, that if you don't cap the health budget, so you say like 10% is what we use on health, it's always going to be a fight between groups, and especially from the populist wings in politics, because it's free to promise more elderly homes, more cancer treatment. It's totally free. So one of the things when you want to go on this prevention and work with numbers is really to have an agreement on what is it we want, right? And how do we define prevention? So when we say prevention, it's not just the primary prevention. So it's very important that it's also the secondary prevention, but defined what is it you do then in that part. So maybe a way to set it up is to say that in these disease areas, which we also heard in the beginning, where we can do things by early intervention, that we define that as secondary prevention and not just a part of the normal treatment budget. And then you can say, okay, this is what we are doing. So our vision, our way of thinking is not that this should cost more money, right? There might be some project money to start it, but the reality is that we have not had more money in the system before. We have not had more people. We want more people, but they don't exist. So what are you going to use the money for, right? So let's forget that we want more money. It's a wrong way to go, and then define it in that way. So this is why we have this focus on secondary prevention. When we start working with it, we thought, yeah, secondary prevention is very logical, so there must be a clear definition. We found 25 very clear definitions. So it's also about how do we articulate this, and the reality is that it's not really applied in a consistent way. So this is also an idea to really prove, and this is where we are looking for partners. So if somebody here in hospitals wants to join us for that, I'm very interested.
Yesterday during dinner, you said something very interesting. So one of the possibilities will be to put a cap on GDP for health. Let's say in Europe, 10% will be maximum.
Yeah.
Okay, which politician will survive?
Do we need politicians?
Since I was for a few years, then I think that...
no, but so...
But I have different opinion. I believe politicians.
Okay,
but anyway,
the
society will survive.
But
because, you know, because the relative numbers means that priority.
Yes.
So if we set 2% for education, 3% for blah, blah, then it's for healthcare system and deal with that.
Yes.
Okay.
So, but this comes into... So where do we have challenges on a management level? Where do we have challenges today in health? It is that 99% of the focus is on acute important problems. It doesn't go into the non-acute important problems. What happens when you only focus on the acute is that you never have time for the non-acute, so they just get bigger, right? So that's the reason for the numbers. And then if you want to do this, you need to build a coalition that's not just political. Who pays today for the increased disease burden? Who has really the struggle of this? Municipalities. So can you do an agreement with municipalities to work with this across that's around? I do think that hospitals and health providers in different ways also have an interest if you build this together. So this goes back to, again, to say this is not just a political challenge. This is about the actors coming in, and if you want a stability in the system, and I wasn't the health minister yesterday, and I saw all the pictures of the many health ministers, and I know why they don't last longer. I have figured out. It's because you only get a picture on the wall when you leave. Huh? So you go out fast.
So sometimes they call you for managing a roundtable. Yeah. Let me share something with you. So we came from another country, quite, let's say, low development anyway. But in this region, primary healthcare was built up. Mm-hmm. So while during my career, I'm trying to promote some attractive words. So I came out with 5P, and I would like to hear your comments. So first of all is promotion of health. Yes. Then is prevention. Yeah. Then is primary healthcare. And I saw your genoma, so it means personalization. Yeah. And then is what is going to be the future, back to the future. So in a way, how we will predict. So the fifth P is prediction. Yeah. So probably you saw the back to the future. So let's say if we will be able to put our society in 2035 or 2050 and try to get information how the hospital, healthcare system, primary healthcare, prevention, blah, blah, will be built, and move backward and try to move to that world. What do you think about that? How to do that change? Yeah, so this is how we work with scenario modeling. And that would typically be that you go 10 or 15 years ahead, and you have to work with stakeholders from different parts of the system so you understand the different complexity in it. And the idea is then to do a really hard stress testing on technology and society. So what happens when you look forward is that we are fairly good at predicting how technology can evolve,
we are very, very bad at predicting what happens with society when technology gets applied. Nobody gets that right. The only one was David Bowie, I think. But nobody listened to him at that point. So we have a model on how we work with that. And this is also the foundation behind the Nordic Health part. So when we did the first part in 2019, and we actually started on a totally different question. We started saying, how can we make the Nordics leaders in genomics and data? And then we figured out that the technology was changing so fast that you couldn't even keep the stakeholders because there were new stakeholders you need to integrate all the time. And then it became a question about what is it really we want? And that was where the 5-5 came from. But we also have 5 Nordic values, right, built in. And we were sitting there and discussing with all these high-level decision makers and saying, okay, how are we going to bind this group together so we actually reach a goal that we can work towards? And then a clever person said, we will find 5 Nordic values. And everybody says, yes, we're very proud of the Nordic values. And then a very naive person like me said, what are they? It took us 1 month to figure out. Nobody knew, right? So this is also a part of these processes that we have assumptions that we think we agree about. But there you really need to dig in and say, okay, what is it really? Because when you want to push, because you need to break down walls, then you need to know more or less what it is you're going for. A part of this is also to be realistic on what is consensus. You don't need 100% consensus. 70% is enough. You have to know which direction, agree on the direction. The direction will also change or be qualified in different ways. But what happens is that once you set a goal where you want to go and you go backwards, normally when you go forwards, as soon as you disagree 5%, you fight. But if you know where to go, it's a challenge that you solve. It's a huge difference. It's very simple, but it's a huge difference in it. And I'll just end this answer by saying, like Augusto Galán, a former health minister in Colombia, always says, if you don't know where you're going, every road is beautiful. And this is how we apply technology in the health system today.
Bogi, thank you. I will conclude a wish. I hope that in 2050, we will meet somewhere and see if our dreams came true.
Thank you so much. Thank you.
I also have the location of that meeting. At the Faroe Islands, you have a beautiful football field.
Yes.
Okay, maybe there,
yes,
if the weather's right.
And we will give the Slovenian players very heavy food tonight.
I will not translate that. Thank you. Najlepša hvala torej prvemu govorcu. V nadaljevanju pa se bomo posvetili temeljem.
Next, we will focus on the foundations of innovation in healthcare, the governance, leadership, and change management. We will welcome Mr. Mark Schreiner. Mr. Schreiner, he is the managing director of the Berlin Hospital Federation. He is also a member of the executive board of the German Hospital Federation and the chairman of the Europe and International Hospital Affairs Committee. He is also the former director for EU policy, international relations and healthcare industries in Berlin and Brussels. In the past, he also shared his expertise as a consultant for a Brussels-based consultancy firm, the Parliament of Rheinland-Pfalz, and the European Parliament. Mr. Marušić will also hold a short conversation after this presentation.
En applaus, prosim, za uvod.
Ask you kindly for a round of applause to encourage our speaker
Thank
to
you
join
very much
us here
for
on the
the
stage.
warm welcome. Yeah, for football, I do not have anything to do with it, but we are organizing now the European Championships. It will take place also in Berlin. And for one game of the Polish national team, we will expect some 200,000 football spectators solely for this event. So we will have something to do that our rescue centers won't be overcrowded. No? So this is my connection to football, actually. Yeah, dear ladies and gentlemen, thank you so much for inviting me. It is a pleasure for me to be here and to talk to you about innovation in Germany. It is, I can tell you, much more practical than we just heard, as I will explain you about what we are doing in concrete. Just to let you know a little bit about the organization, I am the CEO of this Hospital Federation of Berlin, representing all types of hospitals, so the public, the private for-profit, private not-for-profit hospitals. You can see here the figures, some 60 hospitals with 23,000 beds and 60,000 employees working for us. They deliver care to 150,000 patients, inpatient services, and 1.2 million outpatient services. And we are also teaching hospitals, we do training, we do research, we cooperate with a very important scene of startup companies being active in the field of healthcare. So we are also innovative. And lastly, we generate a gross income of 5 billion euros. So we're not only healing patients and the people of Berlin, but we are also a very considerable branch for the city of Berlin. So it is even more important that we have innovation, because in healthcare, stagnancy of innovation means regression. If you stop being innovative, you will be old, you will be able to offer old care at the next day. So this is an ongoing demand. And for today's speech, I brought with me some 3 focuses which I want to explain to you. One is about medical care that we have in the Innovation Fund we will talk about. This is also about the processes in healthcare, where we have initialized the Future Fund. And finally, it is about innovation in organization of care. We have, since last week, a new tabled law concerning big hospital reform. So this is the journey we will do today. Yeah, about the Innovation Fund, just some technical things. It was inaugurated already in 2016. It is active, member-driven or stakeholder-driven process. We have an innovation committee which consists of hospital representatives, representative of doctors' organization, and of health funds. And this is, let's say, a committee of our health parliament. In Germany, we have an own parliament for healthcare, the so-called Federal Joint Committee. And this Federal Joint Committee has the right to set binding rules. So this is like a small parliament, and therefore was built this commission. And these representatives, they are supported by a great pool of experts, so doctors, health economists, lawyers, all the professions we need in order to analyze the projects, and they will produce opinions if a project is good, if a project, they can give recommendations at the end, if a project shall be implemented into general care, and therefore they produce reports. This fund is also about a lot of money. Altogether, we spent 200 million euro per year since 2016 in order to have innovative approaches in healthcare. And we have 2 directions on which we do this innovation research. The one is on provision of care. So there, new models of healthcare delivery are developed. So I will, for each of those 2 pillars, I brought an example with me. And there we also especially try to overcome the borders between the sectors, so between primary and hospital care, for example, or between hospital and rehabilitation. And therefore, this innovation fund has this 160 million euro per year. And the second tranche is about health services research. There, in this sector, we do analysis of the daily experiences and routines, whether they can be improved, and whether there are already innovative solutions to improve these daily routines. And then even these new solutions are assessed. But this can also mean that clinical guidelines or the binding rules of the Federal Joint Committee may be improved. So this is the second tranche. And about all this, we make it very transparent. We have an own website, open to everybody, and every project with its applications, with the decisions, with the reports and recommendations of the experts, with how much is paid for which period of time, every information is available on this website. And finally, that's not only about research on innovation, but also into implementing it into practice. We, not since 2016, but now then since 2020, we have a second part of it's a rather complicated procedure on how to implement good projects into practice. And since it started in 2016, we have realized or actually running almost 600 projects. Now I have two examples brought with me. The first one, I have chosen them because both of them are managed by one of my member hospitals, the Charité, our university hospital in Berlin. The first one is pre-free, means a project which is installed for 3 years. It's actually running, and totally it will get 3.8 million euro. It is about preeclampsia, which is causing high risk for mother and child during pregnancy. The symptoms of this disease is high blood pressure and proteins in urine, and it can cause life-threatening complications for the mother and the child. But the problem is, there are no reliable methods to predict complications for this preeclampsia. So often unnecessary admissions of mothers to the hospitals are happening, or they are not aware of their preeclampsia and don't come to hospital. And then for sure we have the problems with false positive or false negative diagnosis. So the aim of this project is to improve the prediction of complications, and therefore the doctors by this project, they get support. There's a learning machine algorithm which can divine on viewing the data if a complication can occur or not. And the data is I was remembered by Phase 5 project, which we just learned. The data is decentralized by machines, by the mothers at home. Several times per day, they can enter the relevant data. And if the results progresses, then the mother is called to the hospital. And now it is the aim to look whether this helps improving to reduce non-necessary admissions and to improve the health of mothers and child, and also to save costs finally. This is Project Pre-Free, and the other one called NOTE. I just last Friday spend a night shift in a rescue center in one of my hospitals in order to see how it works in practice. And there I learned also that assistants were running around asking patients and also staff for this node project. For this reason, I just brought it with me. It's also organized by Charité for 3 years and gets approximately €1 million of funding. And there we have the problem in Germany that I learned that you have the same here in Slovenia, that our rescue centers are totally overcrowded by patients which usually would need primary care only, but which don't find any appointments, nor at the general practitioners or primary specialists. So they come to the rescue centers and then get angry very soon, very angry, because they do have to wait. What we need is to better steer the patients, to avoid them coming to our centers. And therefore, we have this project Node, which tries to find out the motivation, and so therefore the patients and also the emergency staff are interviewed. They are interviewed on the basis of a catalog which was developed after reviewing international studies. These international studies, they are about which other projects of access to rescue centers do exist in other countries. And finally, we are measuring the real patient flow in our rescue centers. So this is just a glimpse of on our innovation fund. As I said, some 600 projects are developed, but I would say this can have really practical effects that we spend this money into innovation. We now come to the next part, the processes of healthcare. There we have invented the Future Fund, and this Future Fund, that's about digitalization in order to improve care, to reduce the burden of bureaucracy, and to make care better. And therefore, we have this, since 2020, this Future Fund. Altogether, it's €4.3 billion, which is co-financed by the federal states and the national level. For Berlin, for example, this means already some €220 million, which our 60 hospitals now can spend solely in projects of digitalization. But it's not free wish concert. You have to apply to a list of projects which are eligible for funding. And I listed them all. That's about modernizing rescue centers for sure. That's most important. But also for digital documentation of care, it is for decision supporting machines, so that doctors via speech can talk. We all know it from home, where we have this Google or Alexa, a speech-driven machine which reacts to on your questions. This is now applied in the hospitals, where doctors have access to artificial intelligence-driven support, decision support. So this is this. We have, for example, cloud computing systems shall be financed with this fund, and also robotics can be purchased, telemedicine shall be enabled, and also cybersecurity shall be enhanced with this €4.3 billion. The federal states, they had the liberty to choose whether in their responsibility the hospitals had to mandatorily implement, and Berlin did, for example, for the patients' portals. We will come to this. The money is not only for purchasing the hardware, software, for the licenses, but it is also to train the personnel, because this is really necessary that you do not have just modern machines which nobody knows to use. So this money is also in to the training of personnel. And we have also a timeline. The projects shall be realized in 2024, with the end of 2024. But we have seen that in Germany we have 1,700 hospitals. When they, at the same time, want to purchase new machines, new technologies, this is totally overrunning the market. So the companies, the service providers, they are not able to provide us with the products. So we postponed already the deadline for the implementation. And you have to know hospitals which did apply, which got money, but did not implement the products till the end of now 2025. They will have to pay 2% of their income as a fine. And I would say this is a great incentive here in order to enforce the implementation of this kind of innovations. Also here I have, as I said, we want to have a look at one of the points here, patient portals. For every of these 10 bullet points, you have very specific requirements what a hospital shall fulfill with purchasing this new innovation. So it's not only funding without guidelines, this is really regulated funding, which we got with a future fund. So the patient portals, they shall reduce the efforts for communication so that a patient easily can communicate with a hospital, and shall also speed up the exchange of information. So that means that the patient can upload his data, for example. The patient portals, they have different tasks themselves. They are there for the admission process, for the treatment and transition management, as well as for the release of the patient. And for each of those parts of the patient path, special requirements again are set up. Now for the digital admission, this as a general requirement of this bullet point, they shall be available to patients before the admission for sure. They can enter their data at home. This is also a general requirement. And they must have options for making appointments. So the patient, via using this patient portal, shall make appointments, can upload anonymous tools or data from his general practitioner, for example. And as a can have, so optional, these patient portals are get money if they have chatbots for supporting patients when fulfilling the anonymous, and the rest are also, for example, if the patient decides to include data from his watch or from his wearables, that this also can be supported by digital admission as a part of the patient portals. So Future Fund, that's a huge project altogether, which leads to a high rising of the digital maturity of the hospitals. By the way, there will be a study rolling out how far the digital maturity of the German hospitals were high-rised by this innovation fund. It will be, I think, good results because we were starting at a very low level. So then it's easy to have a good augmentation of the digital maturity. We now, with this big project, we will have future problems. First, we need to have more financing in the running costs for the additional hard and software. And what we also need is to have more IT specialists. It's also making more severe even the lack of workforce. We are in a strong competition with big companies for IT specialists. So we are good consulted if we try to produce our own IT stuff. If we do not have a nurse, we might close a bed. But if we do not have an IT specialist, what is happening then to the whole hospital? So I'm proud also to present a small innovation. We as a Berlin Hospital Federation, together with the university in Berlin, we designed new studies, 3 years bachelor studies, IT specialists, specially tailored to the needs of hospital. So there will be tech translators, IT architects, and they will also have a capacity, competence in order to motivate the staff to use the new innovations. So this is now our look at the Future Fund. And finally, due to the time, we come to the innovations on the organizational level, and there we come to the hospital reform. It just was tabled last week, so there have been the decision of the Federal Cabinet to bring this draft law, despite that the Minister for Health started the process already in December 2022. And since then, he managed or managed not to organize this fully complex process. We have in Germany another constitution, for sure, than you have here in Slovenia. We have, for example, federal states with a high level of competence concerning hospital care. Hospital care is in the responsibility of our federal states. So national level hardly only can overcome this federal state's competence by tabling a national law. But this is what the minister just did last week, and this is the reason for which the federal states already announced that they will try to hinder this reform, despite that everybody in Germany says we cannot continue with the hospital care like we do. Everybody acknowledges the need for hospital reform due to lack of health workforce, due to lack of finance. And so the motivation for this reform is totally agreed on. And I must say, even the approach by the minister was perhaps a small innovation. He did not, as it is usual, first consult the associations and the hospitals and doctors, but he invited a circle of experts, professors from universities who draft a paper, a hospital reform paper, and then he presented this to the public. And I would say this has been an interesting approach. But now that we learned about the results of this process, nobody is in line with this. So I would say we have a small chance or a small risk that this reform will come. The legislative period, it's fading out. We will have new elections in September 2025. So if the reform isn't realized by the beginning of 2025, I think we won't have any reform at all. And this is not good, because this reform shall also make better the financing for the hospitals. We have lump sum payment, and the prices we negotiate with the insurance companies, they are only allowed to raise with a ceiling by law. And this ceiling prohibited that the high the high inflation of the last 2 years was refinanced. So we are actually by only in Berlin for this year in an underfinancing of 400 million euro, and we need a law in order to get more money, but now we are in struggling concerning the content. The content of this reform, this has two main pillars. The one is financing, I just talked about, and the other one is about hospital planning. The major aim of this reform is to reduce number of hospitals and to lead to better specialization of hospitals. There is a rumor that every hospital can treat everything. May it be so little, and in a rural area they can do everything, or they do everything, and this is not true. So also the Länder, they need also small hospitals in rural areas as a basic supply. This is something else for Berlin, where we have 4 million inhabitants only in the city. We are a growing city. Every year, 40,000 people coming additionally to Berlin. So despite that, we have a higher potential to treat patients also in hospitals, more ambulatory. You have to provide hospital beds. And so this is already showing that between the different regions and the different cities, it'll be very difficult to just reduce the number of hospitals. Also, we have to talk about war, that it is not excluded that the Russians will perhaps also invade Poland, and then we have, or even Germany or another country, and then we have a war inside of Europe. And therefore, we are getting prepared. We are, since a year now, having official debates about how to make hospitals resilient to war or to civil catastrophes. And this won't be possible with a landscape of hospitals which is massively reduced. So this is, let's say, multifold access to this reform. We just started last week. I think you will have the opportunity to follow it up till the end of this year. And what is also interesting in all this, there will be a fund for the transformation. So if we close hospitals and beds, then we would need to create other capacities in the remaining hospitals, so grow them up. And therefore, this 50 billion euro fund is foreseen. And also this is, let's say, critical because our health insurance funds, they should contribute with a half of it, and they are not there in general for investing, but for paying the running costs. Yeah, and finally, we are dying by bureaucracy in German hospitals. Really, a doctor in general spends 4 hours of a shift with documentation, a nurse 3 hours, and it's getting more and more. Just 2 weeks ago, we got a new transparency register. Hospitals, there are already registers existing, yeah? Hospitals now have to additionally put all data into this new official register, including the minutes a doctor is spending for a patient, in order to make visible how much time staff is spending on patients in that hospital. So this is so much bureaucracy you can imagine. And now with this new hospital reform, even more bureaucracy is added. So I just said 2 weeks ago in an interview, it might be an interesting business model for hospitals to skip healthcare and to do only bureaucracy. Yeah? I think it would work out. So these are the challenges we had with this hospital reform, but some food for thinking, perhaps also for the discussion. Everybody agrees into the need of this reform, of this innovation, but nobody wants to implement it. So it'll be interesting how to resolve this. For the moment, and right in time, I thank you for your appreciation. We can stand. You can stand.
Yeah. Mark, thank you for your presentation. You know, more or less, Slovenia copied the German healthcare system. insurance, structure, and other things. We are very close connected. So following your presentation, we just divided. No, we should thank you. No. Anyway, you cannot figure out how unsatisfied are we with our healthcare system, so without your help. So anyway, I was always figuring, you know, your country, your hospital and so on in our figures and so on. But let me explain Slovenia. 2 million inhabitants, 27 hospitals. From the Second World War, how many hospitals has been closed in Slovenia? From 1945, how many? It's easy.
I think none, but
only one. It was a pediatric hospital in a small village in Vipava. Yeah, so one. In between, we built a high road and all other things. So no one. Several attempts of reform has been, to reorganize, to restructure hospital. Everybody was for. When we presented, everybody was against. So, besides funds, which you mentioned several times, what is, for your opinion, the main ingredient to convince people that they should move forward, to make a change?
So the minister, he did already, I would say, a good approach, because with this innovation to ask a group of experts before and to have a reform approach designed by them, I would say this was already good, but the content now is disturbing. So this won't come through as this. But I think it was a good access. For the hospital associations, we have the great incentive that our hospitals are going bankrupt. We have had last year 48 bankruptcies of hospitals in Germany. Fortunately, in Berlin, none so far. But this is showing already how much we are running out of money. And we did not talk yet about how we are running out of personnel. We have 15% less services in comparison to before the pandemics. 2019 is our reference here. So 15% less of services. This means also 15% less revenues due to lack of health workforce. And this is for us a very strong incentive that we have to have changes. We need to reorganize our hospital care. And this is then bringing the next problem. If you think that the staff of a hospital which is closed will just go to the next hospital, no, this won't happen if you don't take care of this. Staff is not any mass which you can just push to the next hospital. You have to convince, you have to go give incentives. So this might be successful, that we can reduce a little bit the lack of health workforce by reorganizing the landscape, but we have to do additional efforts to earn the fruits.
Years ago, there was an attempt that a hospital in one region in Slovenia will move to our community. So be much more connected with the primary healthcare, with the community. Unfortunately, the pilot failed. What do you think about that? That hospitals should be the one to move outside instead of open the door and increase the inflow of patients.
Yeah, this is, I would say, necessary. In Germany, even in Berlin, which is a highly attractive city with a lot of young people, and so our Primary Care Doctors Association is not able to fulfill every vacancy. Not for the general practitioners, not for the specialists. We have also specialists working in primary care. And you can see, especially in the eastern part of Berlin, where the people which do not earn as much as in the western part, there the vacancies are even more relevant. And what is happening then? People don't get any appointment at their general practitioner, nor at the specialist, so they come to the rescue centers of hospitals. This is already one big problem. But this overcoming of sector borders is also enforced by law. We have, for example, more and more allowances as hospital to deliver ambulatory care. We, as an association, together with the doctors, we admit our hospital doctors for provision of primary care. And this is one next big enter of the hospitals into outpatient care. Then we have a lot of special ambulances where ambulatory care is provided, which you cannot find by outpatient, also by primary care doctors. And finally, we have two new instruments. One's the hybrid DRG, so DRG, that's our lump sum payment system. And there we developed a catalog of hybrid DRGs, which enables the hospitals to deliver care or as primary care or as outpatient care. The aim is to, in midterm, reduce the number of inpatient care and to have more outpatient care. And finally, we can have more day cases in hospitals. This is also primary care. So the switch from inpatient with very expensive, cost-intensive, personnel-intensive hospital structures back to more smart ambulant structures. This is enforced by law even.
Years ago, I found a figure that each country has to invest 2% of additional funds every year for innovation. Yeah, so, but I will refer to Bogi because he said that he will cap. Once I also have this idea, I was being a minister, said I will frozen the hospital budget, but I didn't succeed. So anyway, if we would continue with this, when are we going to end? 100% of GDP is maximum. We cannot overpass.
Oh,
yeah, but I think that majority in this room and Slovenia will be for 100% for health. I would never bet.
Yeah, what is the threshold which is adequate? Yeah, this is a decision of the society in a region. Yeah. What do you consider together as adequate payment? So at once. At second, if we then by coincidence would in Europe all say 10% is the threshold. Yeah, so then what do you get for 10%? Then it's again a question of organization. If a system is organized in a very efficient way, you get a lot for 10%. If you organize it like we do, you get a bit less. So then you have inequalities of what you get for 10%. So I would say we leave it to the people in charge at the political or administrative level and to the society to decide what's best.
To merge both presentations, should you think that we should change the name of the system? Instead of health system, should be disease system?
This is, I would say, a philosophical question. We treat diseases, but our aim is health, so I think both is accepted. Yeah.
Mark, I just want to be more positive. So I will conclude with another quote. So we will let you beat us in final. Germany against Slovenia, you can beat us. If we will be second, we will be happy. So see you in Berlin.
Accepted. That's a deal.
Yeah.
Thank you very much, Mr. Mark Schreiner. We copied your health system, but we made our own bureaucracy. We are very good at that. Več kot 30 let se z ekonomiko v zdravstvu.
Now, the Slovenian Association of Health Economists has been working on health economics for more than 30 years. The vice president of the association, who is also the member of the Association of Hospital Directors of Slovenia, Mr. Tušar, will be our next speaker. Mr. Tušar is a lawyer with many years of experience in healthcare organization. He began his career in 2002 at the Office for the Prevention of Money Laundering. In 2007, he became part of the team at the Idrija Psychiatric Hospital, of which he also became a director in 2012. The hospital, under his leadership, became a leading hospital and developed psychiatric activities, introduced the new healthcare programs, as well as community-based psychiatric care. He remained the director of the psychiatric hospital until May 2021, when he concluded his third consecutive term and took over as the general director of the Directorate for the Development of the Healthcare System at the Ministry of Health. In 2022, he was appointed as the director of the Regional Office of the Health Insurance Institutes of Slovenia in Ljubljana, and today he will talk about the importance of economics in healthcare and improving the organization of healthcare. I would like to give Bogdan, since I've known him for over 25 years, the floor and welcome him to join me here on stage. Thank you very much, and good afternoon, everyone. First of all, I'd like to thank the Forum for inviting me and for co-organizing this conference together with our association. I'd also like to thank the Association of Health Institutions of Slovenia for introducing us to Mr. Schreider today and for helping us to bring him to Slovenia. I don't know if you are familiar with our association. We are very active in the area of healthcare economics. Let me first introduce our association. We are a central expert association operating in the field of economy, law, and organizational practice in the field of healthcare. It brings together doctors, pharmacists, lawyers, directors of health institutions, directors of pharmacies, as well as other top and middle-level managers working in healthcare. Our purpose is to draw attention to the fact that the role of economics in healthcare is of crucial importance. We would like for this role to also be recognized. We would like for our suggestions and proposals to be realized in the future. Now, every year, our association issues two proceedings which basically summarize our meetings, in which our members describe the key areas of the healthcare system in Slovenia, the solutions that we are coming up with, the problems that we are delving into, and so on and so forth. The latest meeting was entitled, "Is healthcare on the right path towards the future, or are we stagnating?" Because our members keep asking us what happened to all of these different measures, how effective they are in practice, are they even being implemented, and when are we going to see the results? Our association focuses on numerous topics, numerous aspects. Some of these are also enumerated here. Of course, we're dealing with the management of healthcare institutions. We are focusing on financing healthcare activities, both in terms of modernizing, for instance, payment systems, as well as for improving access to data, which allow us to better evaluate the value of healthcare services. This also allows us to come up with an efficient cost analysis. And then we also talk about the accessibility and resilience of healthcare system, the management of different risks, from clinical to financial to information risks to corruption risks and so forth. Our association also focuses on the so-called soft issues, for example, the development of staff, the increasing of their competences, and intra-generational cooperation. We know that staff shortages in healthcare are a very huge problem, which also prevents us from embarking on further development. The association started operating in 1992, and our long-term members say that time is running, but the problems are always the same. I would particularly like to focus here on the efficiency of the healthcare system, because very often we see that we are hostages of some time constraints, that the healthcare system is stuck in some type of routine instead of trying to reach the goals and objectives that we see in Western Europe. We always had problems with space, with the accessibility and availability of healthcare services, and what is most crucial is, of course, the lack of individual experts, specialists in individual fields, the lack of competitiveness of the employment in this respect, as well as the lack of staff in general. What is also crucial, and this is something that we would particularly like to focus on, is the lack or the inefficiency of existing premises. The premises are insufficient in order to provide and are not enabling us to provide the most modern services, and we believe that in the future we will have to strengthen investments into improving working conditions, not only for our staff but also for patients who are requiring daily care. We also need to be aware of the fact that our association includes members coming from the very front lines. These experts are dealing with problems on a daily basis, and that's why they also sometimes see immediate solutions. However, the problem is that very often they feel like they do not have a voice. Our association often hears that the Slovene healthcare system is requiring more money in order to resolve all the problems. In our opinion, money as such will not bring about more services, it will not guarantee better services. What we believe is necessary to do is to change the operation of the healthcare system, particularly when it comes to the optimization of individual processes at systemic level as well as at the level of individual institutions. It is also crucial to monitor the productivity, effectiveness and efficiency of employees. This is an imperative in the public sector as a whole. We are convinced that there are still many different ways for improving the effectiveness of operations in the healthcare system, of course, by taking into account the safety and security as well as the reliability of services. We also need to bear in mind the role of the payer of services as well as the role of the ministry. In the system that we've had until now, where the budgetary constraints are very strict and the plan of work, so to speak, is determined by the government, it's very difficult to expect that the payer of these services will also be a very active or efficient purchaser of services. The healthcare system should be able to live to its fullest potential if we make sure that the necessary activities can be adopted and take place in practice. We also need to do more to map the actual needs in the healthcare system. We also need to provide an answer to the question, what type of healthcare system do we actually want? And in this respect, I think we need to regulate this division, the separation between the public and the private part of the system, of course not on account of the public system. The financing models in healthcare are something that economists have been drawing attention to for many years. These models need to be reformed. Cost analysis needs to be done, and the payment should also be directly linked to the outcome of treatment, to the quality of service, and to the actual necessity of the service. Economists also say that Slovenia needs to embark on a huge shift forward in the field of digitalization. Our systems are fragmented, they are not interlinked. Exchange of data is impossible for numerous reasons. We did have plans for changing the system, but many of these plans either failed or got stuck in some drawer somewhere. We also need to make the employment in healthcare more attractive. We need to incentivize remuneration, not only for nurses and doctors, but also for management staff. We also need to be aware of the fact that people tend to leave the healthcare system. And again, I'm not talking merely about medical staff, but also about cleaners, chefs, servers, and so forth. And this is something that needs to be resolved in the future. The managers of healthcare institutions should also get more competences as well as more responsibilities. But we also need to make sure that they are more independent and autonomous in conducting their activities. We also need to make sure that new technologies, new innovations are implemented and took much quicker than until today, because the system that we have now is actually hindering the uptake of innovation and new technologies into individual processes. We should also draw attention to the best practices implemented by the Healthcare Insurance Institute of the Republic of Slovenia, especially when it comes to the decrease of administrative burdens. Our association also claims that we need to change the accounting system for healthcare services. We need to employ people who are experts in accounting, who are experts in mathematics and payment models, and not expect that medical experts are going to do that type of job, because we also need to make sure that we employ sufficient number of people who are responsible for keeping the so-called lists of codes which are necessary for payment services. And last but not least, we need to establish a good cooperation between different experts, not only medical experts, but also lawyers, legal experts, economists, and others, because only by working together we will be able to change things for the better. And also what is imperative in doing so is that we involve the civil society, particularly patients' associations, as well as patients themselves. They are of crucial importance. We often hear how healthcare should be patient-centered, how patients should be at the forefront of all activities in the healthcare sector, but we also need to involve them in any reforms. This would be very briefly on my part about our activities, and was always advocating the strengthening, the reinforcement of the public healthcare system in Slovenia to make it fit for the future, to make it able to face challenges and to provide for a affordable and affordable healthcare to everyone based on the principle of solidarity. Thank you very much.
Hvala lepa Bogdanu Tušarju.
Thank you very much, Mr. Tušar. Because we are very innovative, also time-wise, if you look at your clocks, we are ahead of our schedule, meaning that we are going to further use it as efficiently as possible. So we are going to continue before our coffee break, but in addition to coffee, you are also going to be served some tasty refreshments. Before we break off for a coffee break, we're going to give the floor to Mrs. Carmen Janša, who has been working at the Jesenice General Hospital since 2017. She has been working there as a specialist in internal medicine and as head of the diabetes clinic. but also at the Health Insurance Institute of Slovenia. From 2013 to 2017, she was the medical director at the Jesenice General Hospital, where she was deeply involved in the quality and safety of medicine, integration between different levels of healthcare. She has also been involved in the Ministry of Health projects. The main topic of the next presentation will be the burden of diabetes for the health system. We have not yet had a good answer to this question, backed up by concrete figures. Until today, we are going to listen to a presentation that will provide projections for the future and how we can use the existing data, making them into meaningful information, how various measures can lead to improvements in our healthcare system, and how various programs can improve the quality of work for diabetes patients. Madam Janša, the floor is yours. Thank you very much, and I wish you all a very good day. Thank you to the organizers for inviting me. I am very happy that I can present to you data about the economic burden of diabetes, relying on the huge database kept by the Health Insurance Institute of Slovenia. Now, this is a moving database, of course, because it is fed with data by healthcare providers. As you will know, secondary use of data is becoming extremely important across the world, but of course also here in Slovenia. The secondary use of data that helps us address the various issues faced by each and every patient. At the beginning of this year, the international journal Expert Review Pharmacon Outcomes and Research published an article that we prepared here in Slovenia and that I'm going to present to you here today. Now, this research that we did was focusing on two objectives that I'm going to walk you through. Our first objective was to explore the cost, the expenditure of total management care relating to diabetes, and to analyze this data as well as to present them as systematically as possible. Our second objective was to prepare projections of the data arising from 2019 as the reference, the benchmark year, and to prepare projections up until 2027 and even further on, up until 2050. Let me first of all present diabetes in general. We know that this is a metabolic, chronic, progressive disease that entails high blood sugar levels, but much more than that. Diabetes overall and in general involves important complications, diabetes-related complications that can be either acute, you will know hypoglycemia and high levels of sugar that lead to hypervascular syndrome and other complications. But in addition to the acute complications, we know the risky long-term complications, the chronic late-onset complications at the microcirculation level, such as eye complications, kidney complications, leg and foot conditions, as well as cardiovascular complications, such as atherosclerosis, which is very problematic in diabetes patients and the main reason for morbidity and mortality mortality in diabetes patients. We are going to present today some heart complications, cardiovascular complications, heart insufficiency, brain vascular problems, peripheral circular system, neuropathy, and other complications. Now, all the complications that I am referring here to are related to direct health expenditure. Looking at the financial burden of each diabetes patient, including the patient's family and also the overall society and the economy, we can, in addition to direct expenditure, also speak about indirect expenditure, such as the sick leave, early retirement, a decreased quality of life, and others. As I have mentioned, today, direct expenditure is important, but we must also importantly take into account indirect expenditure. Why am I starting with such a detailed mentioning of diabetes-related complications? The reason is that we've broken down the costs into various groups, including the group of diabetes treatment in various outpatient clinics across Slovenia, adding to that all diabetes treatment, drugs and medical devices. Another group deals with acute complications, and all the other complications that I've mentioned are grouped into one specific category, accounted for by a specific expenditure line. As you can see, the first group, diabetes, is the largest expenditure, followed by heart complications, and you see in the pie chart the various other percentages. Now, in order to fill these categories with concrete data, we have been taking into account all the different types of healthcare services, including inpatient treatment, medicines, medical devices, dialysis, rehabilitation, and other services connected with diabetes. The biggest share of expenditure is accounted for by hospital care, followed by diabetes medicines and diabetes medical devices, and then there are other percentages that you can see on the slide. Looking at all these different healthcare services, we've combined these services with the various patients, or complications rather. You can see that with some complications, the major part of expenditure is accounted for by hospital treatment, except for diabetic nephropathy and eye complications. Together with preventive care, these last complications are managed at the outpatient basis. Now, more than 80% of expenditure is accounted for by medicines and medical devices. Importantly, to mention is that in Slovenia, we are very good in offering our patients, providing our patients with the state-of-art modern drugs. Type 1 diabetes patients can use, for instance, insulin pump, and also the closed-loop-based devices. Results in the youngest population and with other diabetes population groups are very encouraging, using the state-of-art medical devices. Looking at the specific numbers, our range of data includes the period between 2019 and 2022. Looking at the average annual value, we see that diabetes treatment and complications treatment accounts for 174 million in this period, a growth rate of about 13%. Looking at the growth of expenditure by groups, the biggest growth rate is recorded in heart complications. Looking in more detail in the various expenditure groups, the average expenditure per capita per patient is 1,108 euro, and you can see this by the specific groups, the overall expenditure and the expenditure per capita. Looking at the diabetes patient only through the lens of management in the clinic, the average spending per patient is 519 per capita. Looking, however, at leg and foot complications and kidney complications, we see that the expenditure per capita is much, much higher. And these two complications represent the biggest burden, followed by cardiovascular complications. We've also prepared data based on gender. Men represent a higher share than women when it comes to diabetes spending, and also the values of spending for men are, of course, higher in the male population. So the men take the highest expenditure. However, when we look at the expenditure per male person, we see that it is 1,300 euros, whereas in women, the expenditure per female capita is 905 euros. So here's the difference. Looking at the costs and the number of patients, both categories are growing with age. Looking at the expenditure per gender and age, we also see that the performance with the young population receiving insulin pumps is very high. Somewhat lower is the performance, the efficiency in the fertile women period. The share of this population in the overall population is about 6%. And this also decreases the amounts in particular age groups. As I said, with the aging population, the volume of spending also increases. Now, our second objective was connected with making projections based on the data obtained, the projections of both diabetes and diabetes-related complications. We used a benchmark scenario prepared by the European Commission, also when it comes to dealing with the aging populations. The reference, the benchmark here is 2019. The reason is the COVID pandemic. If we used any later year, the data would not be reliable. Now, the basis is the data arising from the public finance as well as demographic data. When it comes to the benchmark scenario, we also use the extended healthy years of life, meaning that because of the extended healthy year of life, costs are transferred into later age groups. Another important principle taken into account is the income elasticity, meaning that the demand for healthcare services from 2019, 1.1, would decrease until 2017 by reaching the level of 1.0. But that, of course, is true of more well-off countries. You can also see here several graphs and diagrams connected with the age and the predicted expenditure for healthcare services depending on the age group. Specifically, I would now like to speak about diabetes here in Slovenia. The share of diabetes spending in GDP is 0.316. By 2030, the projection is that the entire costs would grow by 19.2%, and starting in 2030, this increase will be slightly subdued and slower. Below, you see details regarding the diabetes treatment. By 2030, there will be a 15% growth rate when it comes to diabetes complications, both at the micro as well as macrovascular level. They range between 21 to 23%. To conclude, I have already presented the details that you see here on the slide, but just for an overall picture, let me conclude by saying that the burden of diabetes and chronic complications, both in Slovenia and in other countries of the world, has been growing. Most notably, the heart complications, the most expensive complications are dialysis and foot amputation or leg amputation. Now, if we imagine the population as the bottom of a pyramid, and if we add to that diabetes patients and all complications rising up on this pyramid, it is important to decrease the base, the bottom of this pyramid, with preventive actions from the very early age on. Pregnant women diagnosed with diabetes should be instructed as to what they can do in terms of prevention within their family. In addition to that, we carry out very good awareness-raising and educational programs in preschool and school institutions. It is also important to have an early diagnosis of diabetes and early diabetes treatment and management, prevention and active search for complications if the diabetes has begun is equally important. I think that in the majority of diabetes clinics, as well as in general practitioners' offices, we already offer a very good range of services. Now, as of next year, we plan to introduce a new accounting system for diabetes spending. Also, new educational programs are being planned, programs intended to even more empower our patients to be able to manage diabetes efficiently. Our management teams, healthcare management teams, should also be able to plan efficiently the budgets for the future, for efficient management of diabetes patients. We at the Slovenian Health Insurance Institute will be able to use the data obtained through this research in order to plan for the future and in order to be able to invest in new technologies intended for the management of diabetes. Thank you very much for your attention and for your interest. Thank you very much. Speaking about new technologies, innovation, we always ask ourselves how widely open the doors are for innovation in the Slovenian health care system. We are going to address this question later on during our round table discussion. But before we do that, I cordially invite you to join us for a coffee break. See you later during the roundtable discussion in half an hour.
The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white.
Spoštovane in spoštovani, zdajle smo nazaj.
Ladies and gentlemen, I suggest we continue. For those of you who are still enjoying your coffee, I'd like to invite you to join us here in the conference room so that we can continue with the second part of this year's 13th strategic conference. In this second session, we will look at our experience, lessons learned, and we will also check how open is the door of the Slovene healthcare for innovation. Together with our panelists, we will also discuss this particular issue at the roundtable, which will be coordinated by Mr. Dorian Marušić. We can recall that he was a professional director at the Izola General Hospital, State Secretary of the Ministry of Health, advisor to the Director General of the Health Insurance Institute, and the Minister of Health itself. But today, I suggest that we give him the floor. Dorian said that he would prefer standing than sitting down. His guest will be Mr. Iztok Štotelj, diabetologist at the Department of Endocrinology and Diabetes, University Medical Center Ljubljana, member of the e-health governance at the Medical Chamber of Slovenia, and the president of the Board of e-health governance at the Ministry of Health. He is also the representative of Slovenia at the SNOMED CT International General Assembly and in the Digital Health Working Group of the Standing Committee of European Doctors. Welcome. Second guest is Dr. Tanja Spanić. She is the patient advocate and the president of Europa Donna Slovenia and Europa Donna Europe. She was diagnosed with breast cancer when she was 26. A good year later, she joined the Slovenian Association of Europa Donna, and ever since then she's been an active member and an advocate for cancer patients. Her work is focusing on national and international levels. She is the leader of the working group of patient advocates at the Professional Association ESMA and a member of the organizational committee of Positive and Olympia. She is also a member of the Health Council at the Ministry of Health and a member of the Ethics Committee at the Oncology Institute. Our third speaker is Associate Professor Urho Grošelj. He has been a pediatrician at the Department for Endocrinology, Diabetes and Metabolism at the Ljubljana University Hospital. Since 2022, he's also been an associate professor of pediatrics and assistant professor of medical ethics, and member of both chairs at the Faculty of Medicine, University of Ljubljana. Since 2013, he's also been a member of the Slovenian Medical Ethics Commission and an alternate member of the Council of Europe Bioethics Commission. His clinical and research interests focus on rare diseases. Dr. Urho Grošelj. Our next panelist will be Janez Poklukar. He comes from a medical family, which means that he was faced with the idea of taking care of fellow human beings from very early childhood. He is a former director of the Medical Center of Ljubljana and the Jesenice General Hospital, for the presidency of the Assembly and member of the Management Board of the Association of Healthcare Institutions of Slovenia, as well as former minister. And our last panelist, Ms. Tatjana Jevševar, the director of the Association of Healthcare Institutions of Slovenia. She is a renowned expert in the field of healthcare management, who has already proven her success in a number of leadership roles within healthcare institutions, including the head of the analytical department at the Trbovlje General Hospital, the assistant director for economic affairs at the Health Center, and the role of director of the Trbovlje Health Center. Tatjana Jevševar, please join us here on stage. And now we give the floor to our roundtable coordinator, Mr. Marušić. Thank you, Martina. socially responsible care for health should provide for the best possible health outcomes, of course, by providing high quality, safe and efficient services. When we optimize the accessibility, this is one of the 6 determinants of quality. We also need to focus on healthcare professionals. We need to focus on an empowered citizen. Empowerment is important. And all of this should pave the way for breakthrough innovations into the system. We need to open up new methods of organizing processes for the healthcare system. I hope that the healthcare system in the future will be able to support a healthier individual along the entire life from birth to death. And I suggest that we start with Tanya, not least for the purposes of gender equality. Tanya and I have been colleagues for many years, and I'm going to ask you something like this. If you focus on the individual, not a patient, on the individual, on a citizen, in order to make sure that we will really focus on health promotion. So in order to improve and optimize the process of this individual, we need to apply certain principles. We have both been participating in the VBHC. So how do you believe we should implement this system in our Slovene healthcare system? Well, first of all, I'd like to thank you for the invitation. We are all users of the healthcare systems, all of us, all citizens. And like Dorian said, we are using the system from the day we're born until the day we die. And of course, the education and training within the healthcare sector is of crucial importance. People who are dealing with chronic patients see that there are numerous problems which are not related to innovation or VBHC, but with the issue of what I call healthcare literacy. Access to information, access to data, hopefully in a single point of contact, and hopefully in an easily understandable language is therefore a must. Why is this so important? Because we should be able to know where to look whenever we need somebody and something or somebody, and that's why we need to come together, all stakeholders. This is something that we have been discussing for many years, but we see that representatives of the general public, of users, of patients, of the civil society are hardly ever present, and if they are normally more or less the same people. So we need to open our horizons, to broaden our view of the entire situation. We have been listening to about the lack of staff, but at the same time we are constantly bringing about new tasks, new responsibilities for these tasks. And I think we also need to take some of this responsibility upon our own shoulders, we individuals. We as individuals should be responsible for our own health situation, for health conditions, so that we will be able to prevent certain issues in the future. Well, you mentioned the issue of responsibility. Slovenia has a Patients' Rights Act. Is Slovenia ready and mature enough to, for instance, start drafting an act about patients' responsibility? We all know about the problems related to diabetes, overeating, smoking, and other problems, as well as problems related to the simple no-show of patients. Would the Patients Association support such an act? Thank you for this question. Many of you present here today have been also involved in the amendment of the Patients' Rights Act. Mojca Senčar and myself, including Franci, who is sitting In the audience, we all said that this should be the act on patients' rights and duties, because as patients, we also have duties. For instance, if we have an appointment, we have a duty to meet that appointment. Of course, sometimes we have problems because we don't even know who to call to inform them that we're not going to make it. So this is another issue, but as I said, we need to start informing people at the earliest possible stage, starting from primary school, from kindergarten, and I think that the Association of Oncology Patients has been focusing on the 12 recommendations to prevent cancer, which are at the same time 12 recommendations to prevent all the other chronic diseases as well, but alas, to no avail. Professor Dr. Groschel, congratulations first on establishing the registry. Where do you see the future of innovation, especially, for instance, from the point of view of this new register of rare non-malignant diseases? Well, here we have to make a step backwards, so to speak. Rare diseases are from a clinical point of view, a very demanding group of conditions. So according to the latest data, there are over 8,000 rare diseases. They refer to all different parts of the organism, all different clinical conditions. So when diagnosed, patients go through the so-called diagnostic marathon. Usually it takes 7 years. They are often misdiagnosed. They have to see a series of specialists, and despite the diagnosis at the end, they still very often do not have the efficient drugs or efficient therapies. And even the most successful countries in the world are able to successfully treat 50 out of these 8,000 rare diseases. And of course, this is referring directly to the lack of information and data that we have in this field. The European Union has recognized the need for a more systematic approach to finding a solution to this problem. And one of such approaches is, in fact, a register, because if you don't have a register, you don't know what's happening. You don't know how many patients you are dealing with. You don't know anything about their needs, about their expectations, about their requirements, about their outcomes. And that's why we believe that there was a need to have a systematic and epidemiological approach, if you wish, towards gathering such data. In 2016, we started discussing this within a targeted research project, and then step by step we managed to build up the register. Step by step we were able to obtain the support of the ministry, and at this point I'd like to thank the ministry for helping us out. The ministry recognized that this is indeed a pertinent need, and of course also I'd like to thank the IT experts at the National Institute of Public Health who helped us bring in the project to the final stage. Of course, when it comes to the actual implementation, this is still a matter of time, because right now we are dealing with organizational challenges that we still have to overcome. What about your position in the international arena? What would this mean for the newly diagnosed patients? More effective treatment, connections with hospitals abroad? Of course, yes. The European Joint Programme for Rare Diseases actually started as interconnecting, as an interface between individual infrastructures. A rare disease is defined as something with an incidence which has 1 in 2,000, or the majority of these diseases, for instance, occur in 1 person per 100,000 or even 1 million citizens. And of course, if you don't join these people together into larger groups, you can't really learn anything from them. The European Union is, in a way, an ideal space, an ideal area, which can, because it can pull together different scientists as well as different patients, and grouping together these individuals with rare diseases in order to draw up lessons, conclusions, to obtain data, and so forth. And that's why we have started with the individual repositories in certain countries, and then later on establishing links between these individual repositories into a network. This, of course, is of huge added value, particularly for smaller countries, which cannot have as much experience as larger countries. We do not have specialized centers for rare diseases. We do not have enough patients. And from that point of view, this network provides an important link between all of these different registries, which, in my opinion, will bring about huge success in the next 10 years. We can come back to this later on. Mr. Stokel, I think today when you were listening to presentations, your heart was probably singing because they were all about digitalization, transformation, informatization, and so forth. Yesterday, we were present at dinner together. What is the difference between electronic health record and the registry? Yesterday, I told you at the dinner we spent together when I was sent to Brussels to discuss this issue, but yet nothing has happened. So maybe you can first tell us the difference between these two, and then we can move on.
Thank you for this very interesting question, a very important one. Now, both forms of health sources are important. To simplify, at the times when we were still not collecting so much information and data about patients, we used registers. And in a centralized way, we recorded data in those registers to have an image, an overview as to what is going on with our patients. This is the history of registers, which, of course, later on evolved and developed. They are still used today. Now, with digitization, we've increasingly been trying. We are still trying. We are not there yet. So we've increasingly been trying to, when it comes to the primary data, to support the use of primary data used by healthcare providers, professionals. So we are trying with digitization to equip HCPs with reliable data, and these are healthcare records. Records and registers are interlinked and intertwined these days. Now, quite often, we still use the terms such as primary use of data, secondary use of data. Primary use of data is supposed to be the data used for their primary purpose, and secondary, of course, at the secondary level. However, the term that is also coming to the foreground is the circular use of data. Circularity is essential here. Also, interoperability of registers is significant. Registers today must be interoperable so that we can combine the different registers to get an overall picture of our patients. Right, this was a short presentation and a distinguishing between the various registers and records. ERSK is something that you've established together with the ministry. What is this? Now, I would first of all like to thank Mr. Poklukar for establishing what we call ERSK. Now, several years ago, we started working on the strategy of digitization based on a number of very useful debates. We realized at that time that the information system in healthcare is being produced and managed without medical doctors. And even if medical doctors are involved in its design, they are not the representative voice of what is really going on in the field, in practice. That, so we have learned, leads to a number of complications, including the lack of communication and the product inevitably is not as efficient as it could have been if medical doctors, that is, healthcare providers, were on board. And they must be on board and included in a formalized way. This is something that Mr. Poklukar has achieved. He has been able to put healthcare providers into the very center of the systems, of the registers. In addition, we have also formed what we called a network of experts for informatization. Now, this network, I hope, will in the future serve its purpose, namely, it will deliver to information-based communities, and they will, this is our hope, be representative system, representative registered. What is interesting, and we have been taken by surprise, when we've established this network, we've actually seen that the European Association of Medical Doctors has recognized our endeavors and have included the topic we have been dealing with into their discussions and working activities relating the EHR, electronic health records. We are not only dealing with servers, bytes, kilobytes, megabytes, and so on. We are importantly focusing also on interoperability, becoming a sort of a model of interoperability. Thank you very much, Janez. We have heard very positive words about your achievements. Now, our system is very similar to the German system. What do you, Janez, think we in Slovenia should do at various levels, HCPs, HCOs, in order to have a faster breakthrough of innovative approaches? Could you also tell us something about the existing framework of providing healthcare services and innovation here? Thank you very much, Dorian, for giving me these questions. Now, we'll listen to our colleague, Bogi, who asked us, do we want more healthcare or more health? And that, I believe, is the vital question. How can we achieve a healthier society, a society that will be able to cope with its burden? In the last years, our life expectancy has increased by 7 years. But in the past, we had about 200,000 people older than 65 years. This number today is 400,000. That is a big difference, meaning that we have a burden that is 4 times as large. The burden of morbidity is 4 times as large than in the past. We also know that despite the longer life, that we are witnessing nowadays. We don't have longer healthy lifespans. And that is another issue that we need to take into account. We've all realized that our healthcare system needs more investment in the area of prevention in order to delay the onset of any chronic disease as much as possible. Now, when it comes to our healthcare institutions, healthcare organizations, I'm very happy that we still have a public healthcare system. However, hospitals and community healthcare centers in the 21st century are different beasts than, for instance, schools or museums. They need different management tools and approaches than, say, educational institutions. What we need in healthcare organizations is a more effective system of management. I agree with Mr. Tushar, without a proper remuneration, we won't be able to do this. It's very difficult to engage new doctors. It's even more difficult to get on board successful medical directors. As for the future, I do hope that new models will be introduced as best as possible into our system. Going on with the presentation provided by our German colleague, Mark, the system of innovation in healthcare is not a cost, it is an investment in our future. Speaking of human resources, we will not be able to survive the next period unless we have a global partnership. And I have said this in the past many times. We need global partnerships working on a common future. If we are able to build partnerships, we will be able to have enough human resources. In 1976, we also had a human resources crisis. We were understaffed with nurses, so we attracted nurses from other parts of the former Yugoslavia in order to be able to provide sufficient nursing staff in the National Ljubljana Medical Center. Today, we have the premises, we have the facilities and equipment. However, we need to, despite, or let me put it this way, despite the understaffing, we are still able to provide sufficient healthcare to our patients thanks to the teamwork at all levels, at the highest medical specialized levels, to the nursing care and assistant staff. Speaking of the future and what we should do regarding our future to have more health and less of a health therapist-based system. Together with Madam Janša, we've analyzed the region of Gorenska several years ago in terms of the health care. Now, the Gorenska region had a very good practice at the primary level because all community centers, that is, primary healthcare organizations, were interconnected. They worked together. What does Gorenska and, in fact, the entire country need today? The plans were elaborated back in 2012. What Gorenska needs is a new regional hospital that will be able to deliver and meet the needs. As Tanya mentioned, health literacy is extremely important when it comes to what we call reference outpatient clinics. They represent the basis of primary care under the auspices of the various healthcare directorates, the National Public Health Institute, but also the National Health Insurance Institute. Looking into the past and into the results, we can claim that we have reached great results. I can tell you, because I've been comparing this to other countries in Europe. Health literacy is important. It is already at a very high level here in Slovenia, but we should nevertheless introduce a special subject in primary schools regarding health care and health literacy. Now, let's continue with Tatjana Jevševar from the Association of Healthcare Institutions in Slovenia. You, in our discussion, said that we have already filled up the primary level. The secondary level, the hospitals, are now to be focused on. Why? Why do you think so? Do you think that we have intentionally empowered and manned up the primary level? Why do you think hospitals are remaining under-resourced and understaffed? Do you think that there is a discrepancy between the manning of medical doctors compared to nurses? Don't you think that perhaps we should still focus on the primary level? Please, the floor is yours.
Thank you for this question. Thank you also for inviting me. As we already learned, I come from the Association of Healthcare Institutions, and I'm therefore representing all healthcare institutions in Slovenia. Now, we've had a discussion on the operation of public health institutions in 2023, and I did tell you that the primary level has in fact been consolidated. Community centers in terms of economy have been consolidated and obtained positive results. When it comes to hospitals, however, we see that the situation is much worse. The positive aspect is that we only have a few hospitals operating in the red numbers, only approximately 25%, whereas some years ago all hospitals had negative financial results. And that's why we have to focus on them, because each and every one of them have their own reasons why they're not able to obtain positive results. Of course, the loss that has been accumulated in the past years and is currently amounting to 205 million euro is, of course, extremely important. 145 million out of these 205 were generated by the University Hospital in Ljubljana. I'm speaking about loss. And that's why we have to talk about hospitals, because if we don't consolidate them, we will not have the opportunities for new purchasing, new innovations, new technologies. If you look at the financing of all public institutions in a uniform manner, we see that the only source for purchasing fixed assets, equipment, which of course is a precondition for implementing innovative processes, the only way to do that is through depreciation. From the economic point of view, depreciation only allows for basic reproduction, which means that there is no basic source for financing innovation in Slovenia. The purchasing of such innovative pieces of equipment, for instance, is somewhat in the domain of more innovative directors and ambitious doctors, because it's very difficult to, first of all, obtain money for such equipment, as well as for then certifying the equipment, because the process was not conducted according to the legal norms. We can only think of the use of robotics when it comes to prostate operations in the hospital of Celje. This altogether accounts for 4% of the total budget of individual hospitals, which is extremely low. And because of these negative business results in the past, we also see that hospitals, even if they receive funding for depreciation, they use it for investments only up to 85%. Why? Because they have liquidity problems and they need to solve those out first, and that's why there is really no room for, no leeway for introducing innovation. Yanni, while you were minister, the government actually adopted some long-term investments in healthcare. Our colleague Mark said that we are focusing on building walls and new buildings, whereas Germany took a different approach, a broader approach. I am not going to say what is anything about innovation, depreciation, and so on and so forth, because this is not my remit. But nevertheless, Slovenia has taken a decision for a very long-term period of time. We don't really know, and we haven't yet been able to use up all the funding that is available, but nevertheless, the legal framework is there. Thank you for this question. Well, it all started in 2019 when we wanted to use the best possible methods for drawing on EU funds. We had two projects. One is the so-called REACT, the second one is the Resilience and Recovery Plan. And in the Resilience and Recovery Plan, approximately 70 million euro have been allocated for digitalization in Slovenia, which is comparable, if we extrapolate this number to, let's say, Germany, approximately 1 billion euro. Now, the director of the Association of Healthcare Institutions is right. As a former director of a regional hospital and the University Hospital in Ljubljana, I always had problems with the renovations of our premises. For instance, the trauma department of the Ljubljana Hospital is operating in a building from 1890 without the necessary air conditioning, ventilation, and all the other facilities. And that's why we wanted to find a long-term solution. We are constantly putting out fires, and we will be able to function efficiently when all of our fires are out, when we will be finally able to say, okay, this is now in order, and from now on we can focus on what our system needs, what staff we need, what services we need, what infrastructures we need, what equipment we need, and so on and so forth. And that's why we adopted the Special Act for the provision of funding for investments in Slovenian healthcare up to 2030. We have allocated 2 billion euro. 200 million euro were also provided for the construction of the appropriate higher education system, both at the level of the medical faculty as well as the faculty for nursing. And because the state is responsible for secondary and tertiary level as well as for primary level, we've also involved primary level in this particular act. And if we listen to the news, we see that these are now functioning very well. We constantly see in the news the new premises or renovated premises for reference outpatient clinics, for emergency departments, and so on and so forth. And I hope that sooner or later we will also embark on the realization of large-scale projects, such as the new clinic for infectious diseases, as well as the renovation of the main building of the university hospital, because those of you who are there on a regular basis know that we have problems with lifts. We have problems with basic installations, electricity and so forth, and we are just waiting for the moment where everything will stop, which of course is far from ideal. But as I said before, we need to reach a situation where we will no longer be putting out fires, but will finally be able to adopt a strategic approach towards all of these individual issues in order to focus on treatment needs and the needs of patients. Well, let's leave premises and buildings aside. In 2003, 2004, Slovenia was considering the construction of a new university hospital in Ljubljana. Unfortunately, politicians decided to scrap this project. Anywhere in the world where I visited new university hospitals, they decided to build new hospitals in a different location, not renovating the existing hospital. Now we can conclude our 20-year acquaintance by saying that maybe in the future Gorenjska, the region of Gorenjska, will in fact have a better system, secondary and primary, than central Slovenia. Now let's leave buildings aside and move back to you, Professor Grošelj. You have set up a new program for screening newborn children, which means that you are placing yourself as a doctor at the very beginning of the life of a future patient, a future citizen, and you can co-create this life. Well, thank you. I'm happy that I don't have to work in a building from 1890s. I'm happy to see that in my line of work I'm able to introduce new innovations, new systems which allow us to be maybe slightly more creative instead of putting out fires that we didn't even start. Now, our colleague from the Faroe Islands quoted Mark Twain, and I think that our imagination can very often help us in building up something with rather little funds. And again, if we look at the broader context, I think that in Slovenia, pediatrics is very well functioning. The network of primary pediatricians, secondary as well as tertiary pediatrics are all quite well developed, if not extremely high, of extremely high quality. I can only hope that we will be able to maintain this standard in the future. So this system functions very well, but this system allows us to adopt a more preventive approach. On the other hand, if we want to focus on primary prevention, we cannot wait for somebody to grow up, for somebody to acquire all bad habits, to make all the bad life choices, and so on and so forth. Because childhood is a window of opportunity which allows us to, of course, if we have well thought out programs, it allows us to, in a relatively cost-efficient manner, to make a difference. And that's why this primary prevention is so important. Yes, I'm dealing with the screening of newborns, but also with the screening program for cardiovascular risks, particularly cholesterol and other problems. And I think that prevention is crucial. Screening of newborns, especially when it comes to, for instance, rare diseases, is entering a very interesting period of history. I did mention that there are approximately 8,000 rare diseases, and only 100 of those are dealt with properly in a way that new therapies are being developed, so that we're not only relieving symptoms, but actually treating the disease. Approximately, I believe, in 10 years' time, we will have a huge huge expansion of this therapeutic approach of efficient gene therapies and others. So there are no more excuses why we should not actively seek such innovations. And of course, if we want to do that, we need to start by screening newborns, because this particular point in a person's life is one of the very few moments where the entire population may have a very comparable results before they start their lives, so to speak. And that's why we decided to intervene in this particular point in time. Then, on the other hand, we have genomics, which again is developing rapidly, and it allows us certain opportunities, certain possibilities which were not available 10 years ago. This, of course, goes hand in hand with the efficiency of early detection of disease in children, as well as keeping up with new developments and new innovations.
Well, we are moving to the left, really, to the early intervention. But Tanya, we are also speaking about welfare and also an increased number of patients that are being managed at an early phase. Now, we heard today about digital transformation. We are all going to be transformed into digital robots, are we? What do you think about the establishment of digital charts, digital records, electronic health records? What do patients think about this? Now, this is a very important and valid question, something that we have been discussing for years. The GDPR may be causing problems not only in Slovenia, also in other countries. What is always important and should be in the center of our attention is the patient, the person owning their data. We always need to ask the patient whether they are ready to share their data for general research. Normally they are. The problem for instance, in oncology are the clinical trials, where data remains locked in clinical research, clinical trials, and after 10 or 15 years, they're simply destroyed. And that is something that is unacceptable. They should be utilized for the common good, for the good of all existing and future patients, of course, with all measures regarding anonymization of data, without doubt. We are still spinning around the same problems today. We have data, but we should make it available. When it comes to electronic records, we still are dealing with issues of accessibility. You know, when your veins are destroyed after your blood has been taken and sampled so many times, you don't want your blood to be taken again. You just want the healthcare professionals to use existing data that is already in the system. Maybe we are not thinking about this today, but in the daily life of any patient, that is something that can make a difference. Why cannot community healthcare centers have access to all different data about a patient contained in the electronic records? This exists. It is paid for by the health insurance undertakings and the health insurance institutes, so it should be utilized in the best manner possible. Data should be utilized for our benefits. The same goes for modern technologies. Digital technologies should bring benefits and advantages to both patients as well as healthcare professionals. If we had more accessible data, we perhaps would not be able to see doctors so many times. Right, thank you very much. We are now going on to another level, to the level of doctors and nurses. In terms of career, we are taking different paths. But Mr. Stotter, are there any possibilities that our paths in the digital world will meet in the near future? What can we expect in terms of our digital journeys for the future? Well, it is very difficult to predict and forecast our future. Nearly impossible. But where there's a will, there's a way. I would first of all perhaps address your initiative regarding laboratories. I deal with data in the European space, and I can tell you that access to data is something that remains unresolved in many European countries as well. Now, at the first meeting of the extended board of digitalization, we tackled the most fundamental questions, namely, we've asked doctors what they need in the IT systems, not the patients. We asked our doctors, and this was point number one at our meeting. It is also on the record in the minutes of this meeting. Some things have started to move, and I sincerely hope, well, I will not dare predict the future, but I can say that I'm a moderate optimist. By nature, I'm a fanatic optimist, but for the sake of today, I will say I'm a moderate optimist. According to my assessment, if we have the sufficient political stability, I think we can look up to a proper development of digitization. When it comes to electronic health records, my first goal when it comes to health records is to use these records in order to have more time to actually talk to the patient. Now, 20 or 30 years ago, or even 10 years ago, patients were still bringing their hard copies, their hard papers around. And what I was doing is I was copying, transcribing these hard copies, papers, into a centralized digital system. But if hard copies are only transferred into PDF formats, we haven't done much. The basic question for me is the efficiency of procedures. Why would I have to transcribe hard copies into electronic formats? Another thing that is also very important for me relates to the discussions that you've just had, the lack of capacities, the understaffing, insufficient resources to do all the things they would have to do. I'm a diabetologist, and I deal with a lot of data, including data based on screening. Screening, when it comes to diabetes, is still not sufficient in our country. How can we resolve this? We don't have sufficient medical nurses. We don't have sufficient premises. We, developed a model which uses data to predict the likelihood of a patient, of a person developing complications. So on a risk basis, with using the same number of staff, we can make a more targeted addressing of patients. Based on clinical data, we can use predictive models to focus in a targeted manner on our patients. When it comes to rare diseases, the same models could apply. Now, when will this become the commonly used model? It's hard to say. The fact is that it's not all up to us. Other people and other organizations should do their jobs too. Well, thank you very much. You were very detailed. Thank you to all of you for your contributions. The fact is that we are promoting the system of innovation today. Promotion is not enough. Could you share with us your concluding remarks and very briefly tell us how, in your opinion, we could actually implement innovations today? We've heard about the innovation in the RSK, in pediatrics. We've heard about the challenges faced by hospitals and primary care. How would you implement innovation into our system? We are starting with ladies. Please keep it short and simple. Well, our association deals with innovation in an indirect manner. And what we've done is we've started to implement innovative systems of managing healthcare institutions and managing people. We've launched 2 new products. The first one is the Leadership School. It is meant for managers and senior leaders, namely managers in healthcare organizations need more management skills to be able to introduce innovative models in their daily practice. The other segment or the other product that is also important is effective human resources management and leadership. For that purpose, we've launched an innovative project called the Human Resources School. It is designed for HR managers and other managers who are responsible for creating the atmosphere, the cultures in organizations. So investments in human resources. Yanis? Thank you very much. Well, the key driver in implementing innovation coupled with strategy is the following. We need, first of all, strategic concepts. In Slovenia, we have the strategy of digitization, but this should be coupled with implementing projects, implementing documents. Also, we must clearly know what objectives we are pursuing and what the goal of change is. The target groups are just as important. Are we targeting the management of hospitals or community healthcare centers? The users are just as important. They should be empowered and educated in terms of implementing change. Thank you very much, Mr. Groschel. Well, for innovation, first of all, we need an innovation-friendly mindset when it comes to healthcare systems. Sometimes we simply think that it is enough to do all the necessary procedures according to the protocols. No one expects us to be really innovative. So the management of healthcare institutions should have an innovation mindset. The management should recognize and encourage us to be innovative. If the preconditions are appropriate, innovation will follow, and vice versa. Well, we have innovation, we have the necessary willpower. We need to start implementing this as soon as possible. Draft regulations are prepared. In part, they are already enacted. That definitely is the case in the area of oncology. We also need to be aware that innovation should be used to make procedures simpler, not to put an additional burden on us. And again, I would like to urge us all to collaborate, to join forces and to cooperate. Well, as a person focusing on digitization, my view is as follows. I know that many issues are important, and I wouldn't like to diminish their value. But in the context of digitization, what would be the key driver? What is the most important item to implement innovation? Well, I think what we need is the standardization of data structure, of code lists, of data in general. We need internationally standardized health records. We do not want to duplicate our work and have the unnecessary overlapping. That is our wish, even our political wish. But how do we do this? We do this by creating the capacities that we still lack in Slovenia, the capacities and capabilities of dealing with the primary data. We need the capacities and the profiles, the people who will deal with how patients are handling all these different types of data.
Thank you very much. I hope that some of these ideas presented here today will be used in the Slovene healthcare system, that the system will be upgraded, and that will serve all of us in the healthy years of our lives, as well as during treatment. I think they all deserve a round of applause, our panelists. And I now give the floor to our colleague Barbara Stegel, who will have the final remarks about this conference. Thank you very much. I made some notes today. However, during this debate, my grey cells kind of shifted elsewhere. And since I am known to have the gift of gab, so to speak, I'm going to focus on something that intrigued me during today's conference. One of these topics is that if we bring the path that the citizen makes through the system as close to him or her as possible, as close to the needs that they have, this will also optimize the healthcare system, also in financial and economic terms, because healthcare is also an economic, not just a social category. The second issue that my grey cells were involved with is the striking of balance between responsibility, both of the individual and the system, and the feeling of safety. We constantly emphasize responsibility which, on the other hand, lowers the feeling of safety, of security among different groups. We've seen rebellions among doctors, among patients, among nurses. It's difficult to get a diagnosis, it's difficult to get an appointment even, and the system is about to collapse. Now, 30% of all costs in healthcare are unnecessary if we heard what Bogi said. 20% of patients in Slovenia don't show up for their appointments. This is a huge potential, huge reserve. Now, where is responsibility here? And I think that these are the areas where the room for improvements and the room for innovations is actually the largest. So I think we need to, yes, adapt and make the path that the patients make through the system as comfortable and as efficient as possible, but at the same time we need to ask ourselves how to boost this responsibility. We should also mention something that we like to call a will to change. Yes, we have it at the political level, we have it in our documents, in our strategies and so forth, but it seems that in practice it's not really present. And I hope that our conference will pave the way for our future endeavors in implementing all of these changes and reforms. Of course, I am touching upon a very broad array of different topics that have popped up in my head as I was listening to our speakers, and I think that these are a very good basis for our next year's conference, because they're all focusing on the upgrading, if you wish, of our social contract, as well as on the comprehensive transformation of our cultural space, of the way we understand all of these issues, which is something that Mr. Eliasson touched upon in the very beginning. I'd like to conclude right now. I'd like to thank our partner, the Association of Healthcare Economists, our distinguished foreign speakers, our participants, Dorian, who has just left, to you, Martina, for creating a great atmosphere, and to all of you who were here present in the room as well as online. So thank you very much, and we'll see you again next year. I would be very brief, not to taint my reputation. Now, the window of opportunity is definitely open. We have already made an arrangement to meet up in 2050 in Faroe Islands, but next year, before that, we'll meet for the 14th time here in Slovenia. So thank you again, and good luck.